experiences as well, similar to Doré today. Okay, well, I won't delay any longer. So thank you so much for joining us today, Doré. So for anyone who doesn't know Doré already, Doré Young is a specialist musculoskeletal physiotherapist at Manchester University NHS Foundation Trust and doctoral research fellow with a special interest in persistent pain and psychologically informed physiotherapy. She leads the low back pain services in the community division and is actively involved in musculoskeletal service redesign, particularly the spinal pathway. Doré was awarded an NIHR Clark Research Internship to explore physiotherapists' attitudes and beliefs about psychologically informed management of low back pain, work that directly informs service redesign and implementation of NICE guidance across Greater Manchester. Well, welcome, Doré. I'll hand over to you now. I'm really excited for what you're going to be sharing with us.
Thank you so much, Judith. Right. Can you see my slides? They're just loading. How's that?
Yeah, yeah, looks good.
Great. Thank you, everyone, for joining today's Catalyst seminar. I'm going to be sharing my journey as a clinical academic physio and exploring how my PhD on co-producing culturally informed back pain care is evolving. So I'll be exploring things like cultural competence, humility, reflexivity, and co-production, and how these ideas are shaping my practice. I'll also be sharing some of what I've learned so far, the good and the bad, and there's definitely a bit of personal growth in here as well. So Judith did a beautiful introduction. So here is a bit of an image about my clinical academic journey. And let me reassure you, the road and path has not been that straight. So I guess initially I was working within a really culturally and linguistically diverse part of Manchester. So I work in community services. Many of you will know Longsight and Levenshume. And when I was working in these clinics, I really saw how social and cultural factors shape people's experience of pain and the care that they need. And that started to generate interest in how we can make physiotherapy more inclusive. But when I explored the evidence base and when I explored the literature, I saw that my patients were excluded from research studies due to literacy, language, and sociocultural factors. And that made me really question, how am I actually supposed to deliver evidence-based care? So as Judith said, I was really interested in psychologically informed physio. So at the time, I was exploring physio's attitudes and beliefs to these newer approaches as they were at the time. I've done a lot of clinical level 7, so all the master's modules and advanced practice, which is really interesting trying to navigate that while you're also on an academic journey. For those of you that haven't done anything like this, I highly recommend the pre-doctoral fellowships. Having that ring-fence time out of clinical practice meant that I could submit publications, present at national conferences, and a PhD application just takes up so much more time than you ever anticipate. I'm not here to kind of sell you a perfect vision of a clinical academic journey. It took me several attempts to get my PhD funded, and that's a very, very normal experience. So I was lucky to get one of the NIHR bridging fellowships, and that really enabled me to do some public and patient involvement and engagement work to really enrich my project and further develop that doctoral application. And here I am doing my PhD in co-producing a culturally informed back pain intervention. So what's the challenge? Why does this matter? Why do we care? So I want to just give you a few kind of bits of information around chronic low back pain in deprived and diverse communities. So back pain disproportionately affects individuals from deprived and culturally and linguistically diverse populations. So if you are from one of the more deprived areas in the country, like Greater Manchester is, you're twice as likely to experience back pain than if you live in the least deprived. But it's not just that, intersectional factors matter here. So ethnic minority groups, so people that self-reported as Black, South Asian, mixed ethnicity or other, report higher rates of chronic pain. So it's much more frequent. People within culturally and linguistically diverse communities not only are more likely to experience back pain, but that their experience has higher levels of pain, disability, and higher levels of psychological distress. So it's here we found that real unmet need. So, what is culturally informed care? So it's care that embraces diverse values, beliefs, and practices. So providing respectful, responsive healthcare. And actually, it's not just a nice to have. We know that the culturally informed approaches have improved patient outcomes and satisfaction. And that was satisfaction of the clinicians as well as the patients. And, we all know what it feels like to deliver good care. So, one of my kind of bugbears is about people kind of framing it, that when you work in diverse communities, there's all these, I'm going to use air bunnies, barriers to care. And I ask you to really question, is it a barrier, or is it that we're not designing care which encourages participations from the community we serve? Are we not including these communities in research? And actually, when you reframe that, what we have with research is a beautiful opportunity to deliver better biopsychosocial care. So, what were the air bunnies barriers that came up in the literature? So, it was the communication between us and our patients. We all know that it can be challenging working with interpreters or people that don't have English as a first language. So that came up. A lack of cultural humility of healthcare professionals, and I'm going to be unpacking that in a little bit more detail. But also, it was about recognizing the barriers to accessing and engaging healthcare services, and this constant issue with we're not including these patients in research, we're not including these patients in the design of services, and then we wonder why they're not accessing them, or there's lower adherence, or the outcomes aren't as good. So this was the kind of challenge. Now, I don't necessarily recognize everybody here. However, I'm sure many of you that work in long-term conditions recognize this conceptual foundation for my research. It's the biopsychosocial approach. And it's widely accepted that that back pain is affected by biological, psychological, and sociocultural factors. See the change that I put in there. Now, this biopsychosociocultural approach is reflected across the NICE guidance for back pain, the NICE guidance for persistent pain, and the World Health Organization. But even though I'm seeing a growing acknowledgement of the role of religious, spiritual, and sociocultural factors in how they shape the pain experience and management, these factors remain really underexplored and utilized within the biopsychosocial model, yet we know they're really important. Now, as I mentioned before, culturally informed approaches, they help. There's lots of research that says they improve engagement, adherence, outcomes, satisfaction. But are we doing enough to recognize these needs within what we call, often in physio, combined physical and psychological programs? And I guess the kind of wider question that I'm exploring through my work is, how can we design back pain interventions that truly meet people where they are, including their faith, culture, lived experience, and at the same time remaining evidence-based and inclusive? And I'm sure that many of you will resonate with this in terms of your clinical practice or academic research. So I think we've got a chat function here. So I'd love for you to kind of put comments in the chat here on what you think about cultural competence. And you might be able to see by my face that I've got a very, very mixed view on this. And in the conceptual foundations that I look at through my research, we're definitely moving from cultural competence to cultural humility. So please do put if you have any thoughts on this in the chat. So it was introduced in the 80s to tackle inequities in healthcare, but read this definition. It's a set of congruent behaviours, attitudes, and policies that enable professionals to work effectively in cross-cultural situations. How's that resonating with everybody? So, and again, just take a moment to reflect in how this might show up or be relevant in your clinical and academic work. But in terms of this model, I really feel like these early frameworks, they position the clinician as the expert and the patient as other. And we all know that these kind of power imbalances can have a really negative impact on therapeutic alliance and outcomes. So it's not in our interest to kind of have this big power imbalance. And it's that sort of fix the other mentality, meet expert, you. And I really dislike that about kind of these traditional cultural competence models. Now, I think one of the other issues that I have with it is that it's it can very easily become tokenistic or a okay, so I'm getting a couple of comments through. Thanks, Caroline, for my first comment. Yeah, absolutely. It's linear, it's single, it's like not multifaceted. And if we think about who we are as an individual, then, we're much more nuanced and complex than that. And Selena, oh, hi, Selena. Yeah, absolutely. So thank you so much for those comments. Um, And I think that it becomes really easy for cultural competence to become tokenistic, a tick box exercise, when actually, you know, we really need to be thinking about understanding values, beliefs, lived experience, perceptions, and I do not see that definition addressing these. So there's this real emphasis on learning about cultural groups. And again, I'm really uncomfortable with how easy it would be to kind of stereotype that. And the positionality of the practitioner is rarely examined. And I encourage you to think about your positionality through this seminar. How do our identities, values, unconscious biases shape the interactions that we have with our parents, and our parents? Um, so I think that one of the other things we kind of talk about power and context and intersectionality, but what I would really encourage you to think about it from a systems perspective. We know that this is hugely impacted on by healthcare systems, political systems, social and infrastructures, and there's no kind of recognition in this in the more traditional models. But what we do see is that things are evolving. So there's been this lovely shift from knowledge acquisition of others to critical and reflexive practice. Now, I don't dislike that there's lots of terms because I respect the nuance of it, but I do feel that it can be a little bit confusing across the literature. And I do understand as well that sometimes cultural competence is used as sort of like an umbrella term in the scientific literature. But some of the things that I've picked up, cultural responsiveness, cross-cultural efficacy. I don't really understand what that one is. Culturally informed, which is what I use in my research. Culturally sensitive, I use that as well. And cultural humility, my personal favorite. Um, but it's interesting because when I brought cultural humility up in the group in the PPIE work, they felt that it was too vague and a little bit unclear about what was actually happening. So I use culturally informed. I really dislike culturally adapted. I feel, again, it's sort of supporting that otherness. I think when we are excluding patients from research. Culturally adapted says, we didn't invite you to do the research, we designed this intervention and we're going to adapt it for you. Now, having said that, some of the culturally adapted research in pain really influenced my practice, but I think we're moving beyond that and we can do better. For me, it's co-production methodology. So I'm working with the community that I serve to co-produce an intervention which is informed by beliefs, values, lived experience, perception. So it's culturally informed, it's informed by their culture. In terms of sensitivity, I use that when I'm talking about things like the consent materials. So I've taken ones from, I've adapted them from other studies, NIHR recommendations, and I've worked with the PPIE group in order to make them sensitive to the participants I'm hoping to recruit. So there's much more of an emphasis on self-reflection, power awareness, accountability, not expertise, which I love. And I think here this slide sort of really brings together some of the concepts that sit at the heart of my research: culturally informed care, cultural humility, and reflexivity. So I see cultural humility about adopting a lifelong stance of curiosity, discomfort, it's hard work, and openness and self-critique. It asks us to continually question how power operates in our relationships, and that could be our daily interactions, our interactions with patients, with colleagues, and how we can develop meaningful long-term partnerships with the people and communities that we serve. It challenges that old idea of knowing about others as if culture's some checklist to be learnt. And cultural humility instead invites us to focus on knowing ourselves in relation to others. So I think cultural sensitivity and cultural humility come from almost opposite angles, but with the same goal. We have to let go of the need to being the expert. And I find this really difficult in some in some settings. We're kind of trained to be the expert, but at the same time, it's about staying open to being taught and changed by what we hear. Now, I see reflexivity as one of the activities that gives cultural humility its structure. So here we turn the lens inwards and we examine how our own identities, values, beliefs, and assumptions shape what we see, how we prioritize, and how we interpret the experience of others. And it's more than just those sort of positionality statements that we tend to use in research. So it's about an ongoing awareness of how privilege, power, institutional norms, and personally I had to look at things like white privilege, and how these can shape everything that we do. So I've actually written it down because I wanted to make sure I kind of shared it right, but I thought it might be helpful for me to think, as I have done throughout this research, about my positionality. So I wrote, as a physiotherapist and research working in a diverse community, I have that kind of insider outsider role. So as a clinician, I understand that I'm in the system. As a researcher, I question the system. But I'm deeply invested in challenging health inequities and inclusive physiotherapy because of my PhD. So there's definitely potentially some bias there. My background as a white British woman, trained within a Western healthcare setting, and I'm without a disability, and that shapes how I see pain, physical activity, and culture. I also identify as a feminist, and I have a deep sense of pride, I'm sure as many of you do, in my professional role. And sometimes I've noticed this can show up in really tricky ways in when I'm navigating power and collaboration within my clinical interactions. So even though I understand and I'm guided by cultural humility and reflexivity, I try and see myself not as the expert, but I still catch myself putting that expert hat on all the time and perhaps not listening as much as I should in my interactions. Um, so I think together, cultural humility and reflexivity move us beyond competence and towards consciousness. And I genuinely believe that that is the shift we need to make if we want our work, clinical and research, to be inclusive and transformative. So, my PhD. I'm going to be using the Medical Research Council guidance for developing complex interventions and the NIHR guidance on co-production. And I think one of the key principles shared by cultural humility and co-production is balancing power. And this can be really, really difficult because a lot of our infrastructure in healthcare and research is not set up to do that. So it's been a real challenge to kind of weave this into my methodology. But think examples like I've separated out the professional and patient focus groups at the beginning so they can be jargon free to encourage confidence, and that people with lived experience can speak freely and they can perhaps share the negative experience without and feeling confident to be able to do that. And then later, we're going to bring the groups together in co-design workshops to create a space of trust, build and maintain relationships, and the shared decision making. Now, it was really, really important to me to be able to include and value, so two and three, the perspectives. And it's been a blessing and an absolute nightmare at the same time. So we're going to be using purposeful sampling, and I'm going to be using the Cochrane uh, Plus framework. So that's a national sort of demographic data collection framework, which I've got to be honest, I'm going to be using it, but it's horribly underutilized across research, and it's really frustrating. It's designed to shine a light on healthcare inequities, but it's only going to do that if we actually bother to use it. So we're going to be using that. Um, and we're going to be so I've incorporated this flexible focus group structure, which has been really important to me and in PPIE. But I have to say, when trying to get additional funding to include interpreters, there's definitely this clash between what funders are saying they want and what they're actually funding. And I think it challenges that model of traditional rigor by saying, well, I don't know exactly who's going to be in these focus groups. I'm going to be running them in different languages. I'm going to have some online, some in person. And we're doing this to make them more inclusive and to include more perspectives and skills. But it definitely challenges that kind of methodological rigor as we know it in that lens. So it's been really, really difficult and quite messy. So if you see me again in 12 months' time, I'll be completely grey, I'm sure. So another principle is this reciprocity. So making sure that involvement in the research benefits everybody, not just me. So I've done some great work with the research department, and they can do things like give your lived experience panels or your focus groups access to some of the trust training. And I'm sure many of you that know a little bit about research have heard about Vocal, a not-for-profit organisation that we work with. They're great to bounce your research questions off, and they've given me so much incredible feedback, some tough feedback as well, which I always appreciate. But they're going to be giving some mentorship so that partners can shape and lead aspects of the project. And again, it really kind of builds those long-term meaningful partnerships. And I think it's so important when we're co-producing work is make sure it's meaningful and not tokenistic. So it's this constant regular communication. There's big bits of your research where you're busy sort of writing away, but the communities that you're working with don't know this. So making sure that they've got kind of timetables and when you're going to be giving them updates. Transparent decision making, equal decision making power is really important, and clear feedback loops. So that you can kind of build trust, sustained engagement, and you want to nurture these partnerships sort of well beyond the life of the research itself. So What I've learned so far, I mean, you can see this is quite a busy slide, and it's nothing, it's, not even touching the iceberg. But I think one of the biggest lessons for me around engagement and working with diverse communities is it's about relationships, and come ready to listen and learn. Every time I do a public patient involvement engagement activity, I come away thinking, wow, I got that wrong, or well, I had absolutely no idea about this element of it. You know, patients are the expert, and they're always going to come up with things that you never even considered. Um, I mentioned vocal already. Just, don't reinvent the wheel. There are so many amazing resources out there, and I'd be happy to do a follow-up email with some of my favorites if that would be helpful. Um, Really important to create safe, accessible, and inclusive spaces. I don't do any of mine in healthcare buildings, so we've done them in community centres, gyms, mosques, libraries. I think I did one in a fire station room, um, just to kind of again think about balancing power. Um, yeah, you've got to definitely when you're working within diverse communities, and particularly when they're diverse and deprived, it's really important to consider the use of multilingual resources, but also more creative ways to share your ideas. So the PPIE panel really wanted an animation of results or the intervention, and they wanted it in multiple languages and to widen access and support low levels of literacy. And we're gonna try funding pending is run some community events. So community launch event, community celebration event to share that animation. I'd really, if I can get some additional funding, I'd really like to embed community champions. So these are people that can't necessarily commit the time to PPIE, but that have great roots within the local community and an invested interest on helping build those meaningful connections. They may well be bilingual, and just, really kind of spreading our roots throughout the community that we serve anyway in central Manchester. So there was loads of things that came through that I was kind of anticipating. So, culturally informed exercise considerations. So same gender groups, awareness of religious holidays and fasting can really influence energy to exercise. But of course, there's always things that you would never anticipate. So, one thing that I think is really worth mentioning is about don't assume that the interventions we deliver are culturally neutral. So, often in pain management, we might be thinking about like relaxation and mindfulness, and often we think about them as healthcare interventions. However, mindfulness has its roots in Buddhist psychology, and there's a really interesting discourse between Christian communities who have differing opinions on whether mindfulness aligns or is in contrast to some of the core Christian faith elements. So that was really interesting. I didn't know that before. And it's not that they weren't willing to try it, but it was definitely something that would need to be considered and explored. So I'm going to explore that more in the focus groups. But actually, there was a whole cohort of people that said about faith-based mindfulness practices. And it's well documented in the literature that prayer, reading religious text, are deeply mindful practices. Thanks, Amy. So feel free to add in the chat. I'm hoping we'll have a bit of time to unpack some of this at the end. But start to have a think about where you work. How might you engage with patients and the public to improve your clinical or research practice? How might you address some of these things? So the power imbalance, how is your space set up for doing this? Or actually, can you think of local spaces that you can do it? Or is it helpful to do it online? Or for your patient group, that might not be a suitable option. I think sometimes in healthcare, we do a lot of quantitative stuff, the friends and family tests or, patient satisfaction questionnaires, outcome measures. But I really would encourage you to think about exploring more kind of qualitative approaches. It's particularly when the communities are diverse, the richness and depth of what you get in focus groups or interviews, it's just so, so valuable. So, what next? So, I've learned so much and I've not even done the main study yet. So, the next stage of this project focus on deepening this co-production work. So there's going to be a round of focus groups, my messy focus groups, online, in person. We're going to do them with interpreters, with multilingual resources. We're going to encourage a separate interpreter for me. So they're going to be run in another language, and I'm really looking forward to that reflexive experience of being on the other side of interpretation. We're going to have a diverse healthcare professional group, volunteers, pending guys. I'm looking at all of you to explore like the systems factors, so the barriers and the opportunities, and how the system's set up to support or not support culturally informed work. In the patient group, I'm going to be looking at lived experience and what does culturally informed care look like for them. And I've got some specific questions I want to explore from my literature review, which I haven't had time to share, unfortunately. Then we're going to work at bringing the patients and healthcare practitioners together for a series of co-design workshops. And building trust and refining and defining the intervention, bringing people together to make sure it's clinically relevant and achievable, but culturally informed. When we've got a prototype intervention, we'll be doing a mixed methods feasibility study, testing how acceptable and workable the intervention is in real world MSK, musculoskeletal settings. So the can we, should we type questions. And the PPI panel is absolutely important to all stages of this study. So they'll continue to play a really central role depending on how much additional funding I can get. I'd love to have them as co-facilitators in the group, but they'll definitely be advising on sort of written materials, the animation, how and when we disseminate, and also the triangulation of the findings. I'm really, really invested in building lasting partnerships between community MSK physiotherapy, local community and faith networks. And the aim of that being to ensure that what we're building together doesn't end when the PhD does, but it continues to shape sort of more inclusive, culturally informed approaches to pain care. And I'm sure I'm going to be beating down all the postdoc grant funders as well. Um, but to kind of summarize in terms of my experience, and I think it's really important to be open and honest if there's anyone here thinking about embarking upon a clinical academic journey. I wouldn't change it for the world. I absolutely love it. It's probably the best thing I've ever done in my career. However, I have spent most of my PhD feeling very out of my comfort zone, and I think that is where the richest growth comes from. And on one hand, it's opened up incredible opportunities being a specialist committee member for NICE, being a reviewer for the British Pain Society, sort of presenting at international conference and, connecting with professional networks to, I was so proud to see my influence in policy around inclusion. It was a really, really, really proud moment, but it is deeply challenging. And I think balancing the clinician and researcher identities is really hard. Adding, being a mom and trying to renovate a house, what was I thinking? But also there can be tension between institutional expectations and what communities actually want or need. And this was a long time ago, but at one point I was told that what I see as the bare minimum, ladies only exercise groups, was a nice to have, but not a need to have. And it's that sometimes there's just this clash of priorities, and I found that really, really difficult. And it's nobody's fault as such. It's just we're all working and navigating a tricky system. And I think the work around cultural humility has been genuinely life-changing. And I know that sounds a bit cheesy. Don't care, guys. It really has reshaped how I think, how I practice, and even how I see myself. But this is deep reflection work, and it involves some really difficult conversations, some difficult feedback. It's uncomfortable, and there's times where I felt quite vulnerable, but this is an important part of honest, inclusive research. And anyone that isn't academic will totally know this, that you have to develop broad shoulders. Research can be tough, rejection, critical feedback, and one or two brutal peer reviews. But I always find it really comforting that some of the academics that I respect the most, so the kind of most inspirational professors, they're still getting brutal peer review feedback or grant funding rejections, and it really is kind of uh, I guess just part of the process. But yeah, comfort and growth rarely coexist. The trick is to get comfortable with the discomfort, and I think that is where we grow personally and professionally. So I'd love to, before I answer any questions, I'd love to leave you guys with a question. And how might you bring cultural humility and inclusivity into your own clinical or research practice? And it's a bit of a whistle-stop tour, so I'm more than happy if anybody wants to contact me separately.
Great. Thank you so much for that talk, Doré. That was so interesting. If anyone has questions, please put up your hand and go ahead and unmute or pop them in. We have both a chat and a Q&A, and either of those are good. While we wait to see if anyone has any questions, I've got a few for you, Doré. So I was really interested in what you were talking about in terms of the focus groups, because I know that it can be really tricky to manage power in those kinds of settings. So I've done some
Yeah,
focus group work myself, and I've used the nominal groups technique, which is like a
yeah.
really structured approach. But I was wondering, what sort of things have you done in focus groups to manage power between, I guess, professionals and non-professionals, where there may be a bit
Yeah.
of an imbalance?
Yeah, and especially when you're working with potentially people that have experienced marginalization or may have experienced difficult situations with the very clinicians that they will be working with. So I also use the nominal group technique. I think it was really a straightforward one when we looked at it with the PPIE group, and it resonated really well with its simplicity and its focus on equal power. And in terms of literacy levels, it's fairly straightforward to use it as well. So, but having those initial separate groups in order to build the trust between the researchers, as in me, and allow people that safe space. I think it's really important to have the right training as well. And I think, again, this sort of reflexive practice, we don't get it right all the time. And I think being able to understand our own unconscious biases, be able to be transparent and communicate when we don't quite get things right. But I'm really hoping to get some extra funding to think about the PPIE panel coming in as co-facilitators, and again these community champions to provide that sort of bridge. So I've got a lot of the co-design is still to do. We've not done that yet, but I'm sure it's going to be really difficult. But fingers crossed, it's going to be worth it. I'm sure it will be, Judith. I'm sure.
And I was
Um,
wondering, because you sort of don't, you give us some hints, but have you got any ideas about what your intervention might actually consist of at this point, or
yeah.
is it far too soon?
No, and it's so difficult, isn't it? Because of course we're trying to balance using evidence-based practice, what it tells us to do, with navigating what's going to resonate with the community that I serve and what they feel is going to be beneficial. So the NICE guidance for back pain recommends physical and psychological interventions for certain subgroups. And so it's going to be that sort of intervention. My literature review looked at third wave psychological therapies, and I'm very mindful of of your role actually, Judith, here. So hopefully I'll do it justice. But there's some really nice sort of newer wave psychological approaches, which there is evidence of physios integrating psychologically informed physio into practice. So a great example is the physio acceptance and commitment therapy program. There's also cognitive functional therapy, which was a bit of an outlier. Um, I work with Zoe Malpus and the Walton Pain Service, and they really like the compassion focused approaches. And interestingly, um, a big kind of component of that is around a shared common humanity, which I think is really nice when you're thinking about community and co-production. But what we saw in the literature review is it's not culturally neutral. So I've got a series of questions around how do patients feel about engaging in practices which are rooted in Buddhist psychology. So there's quite a few questions. How do they feel about talking about evolutionary like when we talk about neurophysiology, we often talk about evolution. How does that resonate? So I anticipate it will be one of the newer wave that influences the psychologically informed practice element of it. But as with true co-production, you can't say too much because every time I go and do it, the patients never say what I think they're going to say.
Well, that sounds like you are doing true co-production then. If you're
Yeah,
being surprised, you're definitely
right.
working in partnership. I
Yeah,
don't think we have any questions in the chat, but I'm just going to
I can
share
see
our
one
sort of,
actually. I
oh,
think
there
there's
is
one
one.
actually.
It was a
Um,
comment. So I think this is
ah,
yeah, so this is
okay.
Yasmin says, thank you very much for an interesting presentation. Great work around developing culturally and psychologically informed healthcare work. Um, so I've just got a closing slide up here, just a word to everybody as well. Just to remind you, if you've enjoyed this and you'd like to hear more about clinical academics, please do sign up for our seminar on Monday. But Dora, so my last question to you is, if people have been inspired by what you're sharing today, what would be your tips for how people can just take their first steps into clinical academia?
Yeah, absolutely. I would completely recommend looking at the NIHR internships. A question that I often get asked is, but I've got no research experience, and that is what they are designed for. And we've got such a great setup in MFT. With Manchester Catalyst, I'm sure I'm happy to speak to people, give them some ideas. I'm happy for, people to be a part in some way of my research, but I would look for a academic within your field and ask to have that one-to-one and see if there's some experiences that we can offer. So someone that's applying in my team for the internship's been helping me with my literature review as a second reviewer. So I normally, I don't know about you, Judith, but a lot of researchers are quite happy to have another pair of hands, and I certainly am. So I'd highly recommend reaching out to someone that inspires you.
Brilliant. Fantastic. Well, thank you so much, Dorian. Thank you so much, everybody, for joining. Really appreciate your comments and your feedback.